Hello, and welcome to another ILD Community Network podcast. The ILD Community Network represents a groundbreaking collaboration between the Association of Pulmonary Advanced Practice Providers, or APAP, and Rheumatology Advanced Practice Providers, known as RAP. Together, these organizations are committed to advancing multidisciplinary education, fostering collaboration, and improving care for patients living with interstitial lung disease. I'm your host, Kelsey Cramer, and in today's episode, the role of APPs in advanced ILD and PH-ILD, and we'll explore how advanced practice providers can help identify patients with progressive advanced disease, recognize signs of pulmonary hypertension associated with ILD, and facilitate timely referral to specialty centers and advanced therapies when appropriate. Joining me today is Jenny Williams, a well-respected clinician and educator with extensive experience caring for patients with ILD and PH-ILD. Together, we'll discuss the clinical, physiological, and hemodynamic features that may signal disease progression, review when referral for specialized evaluation or lung transplant should be considered, and examine the critical role APPs play in coordinating care across the patient's journey. Jenny, thanks for joining us. Let's get started.
Nice. Thanks for having me.
Okay, so to begin, how do you define advanced ILD and also PH-ILD? And what clinical features should prompt our listeners to recognize that a patient may be entering the high-risk stage of that disease?
So advanced ILD is more of a significant functional, physiologic, or radiologic impairment. And these patients typically have pretty significant disease on HRCT with end-stage fibrosis. Many of these patients also need oxygen with exertion, sometimes at rest. And a lot of them also end up with PH-ILD or have it already. So PH-ILD is part of the WHO Group 3 PH class and is defined on right heart cath with a mean pulmonary artery pressure of greater than 20, pulmonary artery wedge pressure of less than 15, and then a PVR of greater than 2 Woods units. So some concerning clinical features that you should definitely pay attention to, and that would prompt me to think about PH-ILD or advancing ILD, is worsening exercise intolerance, shortness of breath, higher oxygen needs. For example, if a patient was previously able to walk a few blocks and then all of a sudden they're struggling to go around the house, like that's a red flag sign. Or if they were needing 4 liters of oxygen with exertion, now they're needing 10. That's all things that are concerning for entering a higher risk stage of disease.
I hear you. So besides those red flag markers that you see, what are some diagnostic markers, such as changes in pulmonary function tests, oxygen requirements, which you kind of just touched on, or exercise capacity that suggest a patient's disease is progressing and may warrant some escalation of care?
Yeah, one of my favorite tests is actually the 6-minute walk test, because I think it can tell you a lot of information. I can tell you about the exercise capacity of the patient, so what their 6-minute walk distance is, if that's been worsening, if that's staying stable. It tells you what their heart rate response is to exercise, which can give you clues into what may be going on. And then also tells you how much oxygen they're using. So I'm definitely more concerned, like I said earlier, if someone goes from 2 liters to 10 liters with exercise, I'm getting a CTA looking for PEs. I'm getting an echo looking for pH and a cardiac shunt. So that in combination with the pulmonary function tests, where you can look for a drop in FVC or DLCO, I think are 2 very important physiologic testings that we use frequently in our world.
Yeah. I like the 6-minute walk test too, because a practitioner like yourself could just do it by yourself, and you don't need an RT or a nurse to help you if the clinic is really strapped for staff.
Yeah, absolutely.
So pulmonary hypertension can significantly impact outcomes in patients with ILD. What hemodynamic or clinical findings should raise concern for PH-ILD and prompt consideration of a referral to a specialty center?
Mm-hmm. Well, developing PH has a 2 to 5-fold increased risk of death compared to ILD without PH. that's a scary statistic. And that's definitely something that we don't want to miss. And so when evaluating patients for PH, I first look at some of their risk factors. So if they have a history of PE, heart failure, systemic sclerosis, mixed connective tissue disease, drug abuse, cocaine use, all of that would make me think about other types of PHs, because we can't forget about the group 1s, the group 2, the group 4, in addition to our group 3 kind of respiratory world. Symptoms I look out for are dizziness, syncope, palpitations, physical exam findings. Typically, you can hear like a loud P2, S2, signs of right heart failure, so JVD, peripheral edema, ascites, and radiology, you can see a CT with enlarged RV, PA enlargement, echo with signs of RV dysfunction, RVSP, that's elevated. That in combination with, looking at the 6-minute walk test and the PFTs, if that DLCO is out of proportion to the spirometry. There's not one test that can tell you all the information, but using it all kind of together, I think you can make an informed decision of sending that patient to the PH clinic and getting that right heart catheterization, because that is really the gold standard. So if your suspicion is high enough, or even if you're like, maybe it could be, when in doubt, just send for that right heart cath.
Just order. Yeah. And then would you order the right heart cath, or would you refer to the specialty PH?
Yeah, that's a great question. I think it's very center dependent and practice dependent. In our center at the University of Colorado, we have a wonderful pulmonary hypertension team. So I typically just send over to them and they'll do the right heart cath for me, no problem, and get them started on all the therapies that they need.
Totally.
So I love that.
Okay, so what are some important responsibilities of the APP for recognizing when patients should be evaluated for lung transplantation? Are there some key triggers or thresholds that should lead clinicians to begin that conversation?
Yeah, I think there are two different perspectives to kind of view this question. I think the first perspective is from the transplant team and those providers. And so what they're looking for is if that patient that comes in has a high, so greater than 50% risk of death from their lung disease in the next 2 years if they don't get a lung transplant, in combination if they have a high, so greater than 80% likelihood of 5-year post-transplant survival from a general medical perspective. So basically what they're looking for is those patients in the lung transplant window. That's not my job. As an APP and ILD, my job is to catch them earlier and send them to the lung transplant team before they get to that lung transplant window. And so some guidelines that we can use, I think the 2021 ISHLT consensus document for the selection of lung transplant candidates can be helpful for us to decide when do we start those conversations and when do we refer? And so what they recommend is really any form of pulmonary fibrosis with FVC of less than 80% predicted or a DLCO less than 40% predicted. If they're requiring oxygen, if they have signs of progression, or if that patient does have connective tissue disease or familial pulmonary fibrosis, they recommend earlier referral, even more so. And that's just because of the extrapulmonary manifestations that require some special considerations. And then obviously because of the survival impact with PH complicating ILD, if I have a patient with PH, that also makes me think, I should start having this conversation.
Definitely. And probably better to hear it from you first, a clinician that they know and trust, as opposed to some new doctor telling them.
Yeah, absolutely.
So the transplant literature often emphasizes early referral, which is exactly what you were just saying, rather than waiting until someone becomes critically ill. Why is early referral so important, and what are some common misconceptions that delay early transplant evaluation?
Yeah, early referral provides opportunities to address potential barriers to transplant. Some common barriers that I'll see are like body mass index. So if their BMI is 36 and the transplant center needs less than 30, like there are things that they can work with the patient on to achieve that BMI. Psychosocial and support issues are also a common barrier. Financial, osteoporosis management, not being as robust as they need to be, so sending to pulmonary rehab. And it also allows, with these early referrals to promote a relationship between the transplant team and the patient so they can already start to trust them on this crazy endeavor that they're about to undergo, and also gives the patients opportunity to learn more about transplant, because transplant is a tough process and it isn't for everyone, and that's okay, but we need to give them the opportunity to make that decision for themselves. And I think some common misconceptions that I hear about are like, my patient is too old for transplant, but honestly, they're doing lung transplants for patients older and older. I have at the University of Colorado, they'll do some in the high 70s. And the other one is, believing that their patient is not a candidate. I think if there's no obviously like blatant contraindications, allowing the transplant team to decide whether or not they're a candidate is more in their lane. Because I've been surprised with some of the patients they'll take, and I love that.
Yeah, definitely. I didn't know about the osteoporosis. Thank you for telling me.
Yeah, definitely. Yeah. Oh, and the other thing is, if one transplant center denies your patient, that does not mean other transplant centers will deny them, because different transplant centers will take on different levels of risk. And so talking to the transplant center that gave you the denial and seeing if they think it may be a better fit for a different center might be something to also think about and consider.
Yeah, that's very helpful. So for patients who may not yet be transplant candidates but are showing signs of disease progression, what therapeutic escalation strategies should we be considering and discussing with the multidisciplinary team?
Yeah, pulmonary rehab. Pulmonary rehab is great. Definitely recommend that all the time. Anyone who's feeling deconditioned, having more shortness of breath, pulmonary rehab. Making sure they have adequate O2 support at home so that they're able to exercise and be active. If there are signs of pulmonary or progressive pulmonary fibrosis, then considering anti-fibrotic therapy add-on for PH-ILD, like inhaled Tyvaso. And then addressing those transplant barriers that we were talking about, and also considering palliative care for symptom management and goals of care discussion, because it can be a very burdensome disease.
For sure. For sure. I know our transplant center won't transplant a patient unless their mean PA is like under 35.
Mm-hmm.
So just like you said, with pulmonary hypertension, making sure that that's identified and controlled before they become a candidate.
Absolutely.
So as disease advances, symptom burden can become substantial. How can our listeners effectively integrate palliative care principles into their ILD and PH-ILD management while continuing to pursue disease-directed treatments?
Yeah, well, you can absolutely do standard of care treatment for ILD with palliative care involvement. It's not one or the other. They can work concurrently together. And that's especially important because ILD patients actually have a pretty similar symptom burden to those with lung cancer. And patients with lung cancer get a lot of palliative and hospice support. And unfortunately, we just don't have that as much in ILD, and definitely an area that we need to work better on. But because those cough and shortness of breath symptoms are incredibly burdensome, they should be managed. And both the ERS and ATS support the use of palliative care for patients with ILD who have severe clinical impairment. So don't be afraid to send your patients for palliative care or to palliative care for chronic symptom management, advanced directives of care, end-of-life issues. But one note I will make is that it's important to consider what medications that they use in palliative care. Our go-tos are kind of like morphine, oxycodone for uncontrolled dyspnea, and benzos, in the setting of anxiety or with coughing. But if your patient is being evaluated for a lung transplant, they're not going to like that. So you want to make sure to work with the transplant team to figure out what you can or cannot use for some of those symptom management strategies.
Yeah, the symptoms are so tough to manage that we need all the help we can get.
Yeah, definitely.
Looking ahead, what is the single most important message that you would like APPs to take away about identifying advanced ILD or PH-ILD, and then ensuring that patients receive timely referrals and access to specialized care?
Yeah, definitely. I would say look at the whole picture. Not one test will give you all the answers that you need. So you need to put all the puzzle pieces together, if you will. And there is such a thing as too late, as we've kind of talked about. If your patient has progressive ILD, start that transplant discussion early, plant that seed in their head, and get them referred over to a transplant center. Because too early is way, way better than too late. And also, don't be afraid to refer to the ILD, PH, transplant specialized centers. I do remember when I was first starting out in general pulmonary, and I would be a little nervous to send my patients over because I was worried that they would judge my care management, or that they would think that the referral was inappropriate. But honestly, getting over that fear was one of the best things I could have done for my patients.
I hear you. I had the exact same fear.
Yeah.
But I think at the end of the day, we're just looking to help our patients. And I think all providers recognize that.
Definitely.
Okay, so thank you so much for joining us today for this episode of the ILD Community Network podcast. We hope today's discussion provided practical insights into recognizing advanced ILD and PH-ILD, identifying patients who may benefit from specialized referral or transplant evaluation, and understanding the critical role that APPs play in ensuring timely intervention and coordinating care. A special thanks to our guest, Jenny Williams, for sharing her expertise and experience. And the ILD Community Network is a collaborative initiative between APAP and RAP dedicated to advancing multidisciplinary education and improving outcomes for patients living with interstitial lung disease. To access additional educational resources, podcasts, and expert insight, and community-focused programming, be sure to visit the ILD Community Network website at ildcommunitynetwork.org. If you enjoyed today's episode, subscribe to the podcast, share it with your colleagues, and join us for future discussions as we continue to explore the latest developments in ILD and PH-ILD care. Thanks for listening, and we'll see you next time.